This conference will now be recorded.
Okay, so my name is Corina Doary. I've worked for the past 29 years at the QE2 in Halifax, and I decided to talk on hernias today, the ins and outs of hernias, because we've seen our number of requests of these have gone up quite a bit in the last few years, and we find them quite challenging. And some people do get confused over the inguinal hernias in particular. So we'll spend a bit more time on those. Hang on. I'm just going to stop this recording for a second. My slides are not going through.
This conference will now be recorded.
Sorry, what was that?
The way that you arrow through them might have changed.
This conference will now be recorded.
Oh, stop.
This conference will now be recorded.
No. So it's supposed to enter, it's supposed to work with just enter and backspace for go forward or go back. Page up, page down, not working.
Do the arrow keys work?
No, just tried. Oh, there we go.
Oh.
Those, okay. So my enter doesn't work anymore. Okay, got it figured out.
Okay.
So I think I'm just going to start right at the beginning.
Yeah, that's probably easiest.
Yeah. Okay.
This conference will now be recorded.
Okay. My name is Corina Doary, and I've been a sonographer at the QE2 in Halifax for the past 29 years. I've decided to do a talk on hernias, the ins and outs of hernias, because we've seen our number of requests for this type of exam go up in the last few years, and some of them, particularly the inguinal hernias, we find quite challenging. So hopefully you'll find this somewhat helpful. And now the arrows aren't working again. Oh my goodness. So the arrows seem to work if I have this open. Can you see on my screen the go-to meeting stuff if I leave it open?
The only thing that shows up for me is your presentation, and I can see your mouse, but it doesn't show any of the little widgets or whatever.
So it's funny because when this is recording, it won't let me do anything with my slides, but when I pause it, then that's the only time.
This conference will now be recorded.
Okay. Okay, it works with my, so do you have a mouse with like a roller on it? Because it's working like that.
Not, I just have a laptop.
Oh,
I've
no,
never.
there it goes. Now it's almost like it needs something to unjar it and then it goes. Because I did that, right? Now it's just using the arrows on my computer. It's working fine.
So
back, up and down. Okay, so let's try to figure this out. Okay, because it's working fine for me. And the other thing here, if when you do, you cannot typically you should be able to see the audience view as well. If you are curious as to what they would see and what you're recording, right on that sidebar there, there should be something called an audience view. Do you get that before when I shared it? Not now, maybe, but when you've got control.
I didn't see it, no. All I see is the go-to meeting window in my slides.
Okay, well, okay, let's just change it back then. There, now you've got the presentation again. Okay, go full. Okay, so see if you can start the recording. Just play with it first.
This conference will now be recorded.
So now just try to see if you can forward it. Like, what about your up and down arrows? There.
Okay, so they're working now. They weren't working before.
Yeah.
Okay.
Now, They got it, doesn't it? Can you go forward and back now?
Yep.
Okay, you feel
Okay.
comfortable?
Yeah, I think rather than pause it, I'm just going to start right now.
Okay, not a problem. Okay, just text me again if you need anything. Okay, great.
Thank you. Okay. Okay, my name is Corina Doary, and I've been a sonographer at the QE2 Health Sciences Center in Halifax for the last 29 years. And I decided to give a talk today on hernias, the ins and outs, because we've seen our number of requests for this type of exam go up in the last few years. And some of them, particularly the inguinal hernias, we still find quite challenging. So a bit of an overview, we'll look at a bit of the abdominal wall anatomy and the hernias, the types, locations, sonographic evaluation, and some of the complications. So what is a hernia? A hernia occurs when anatomic structures squeeze through a weak spot in surrounding muscle or connective tissue called fascia. It occurs in areas of natural weakness. So where the vessels penetrate the abdominal wall, for example, as in a femoral or Spigelian hernia, or where fetal migration of testes, spermatic cord, round ligament, etc., have occurred, as in an inguinal indirect hernia. And it also occurs through broad flat tendons called aponeuroses, and that would be a direct inguinal hernia example. Hernias do not occur through the belly of a normal abdominal wall muscle unless they've been surgically incised. So you can have surgical hernias as well. And there it goes again. Oh my God, it's not working.
My gosh.
So I'm just going to play with it a bit, and if she can edit this, I'm just going to keep going. Let's just see if I can get it to smarten up again.
This conference will now be recorded.
Click there, click there. There we go. Okay. So hernia contents may be fat, which is the most common, may have bowel loops in them, or even other organs. They may be clinically diagnosed. They're usually able to be clinically diagnosed, but in the days of COVID, I find that a lot of patients are having phone interviews with their doctors. So we may start to see even more requests for these in the near future. CT or MRI are the standard imaging modalities, and ultrasound is emerging as an alternative. And in Halifax, at least, it's a very common alternative. So the abdominal wall anatomy, we're just going to touch briefly on. Basically, there's a lot of layers of muscle here. The rectus abdominis muscles has a layer of fascia in the middle called the linea alba, and we see a lot of midline ventral hernias in this area. Hernias can also occur lateral to the rectus muscle, in the groin, inguinal areas, which is one of the most common areas for hernias. So just to look at the different types of hernias that we are asked to look at sometimes, epigastric, umbilical, groin hernias down here. So you can see how these are fairly close together. So these are the ones that give us the most challenge to decide what type we're dealing with. There's two in particular, the direct and the indirect. We'll spend most of our time on. They occur very close together. So again, just another look at the different types of hernias. Midline hernias, usually you're going to describe them based on the level that they're at. Epigastric, umbilical, umbilical and infraumbilical, etc. This diagram here shows a type of hernia that wasn't in the other diagram. So the one that occurs lateral to the rectus muscle is a Spigelian hernia. And then we have our inguinal hernias here. We'll touch briefly on lumbar hernias. They're rare. We don't see them very often, but sometimes we get them. So midline ventral hernias, like I mentioned, they are described based on the level that they occur in, and they occur in the midline. They're easy to find. If it's not readily evident where it is, get the patient to perform Valsalva maneuver or do an upright if necessary. So if the patient tells you that the swelling or the hernia only shows up when they're standing, then you need to stand them up to take a look at it. Again, just a simplified version of midline hernias. These ones happen to be containing bowel loops. Incisional hernias, depending on where the incision was, can be anywhere on the abdominal cavity. Just going to spend a minute talking about diastasis recti. So this is a midline separation of the rectus muscles, which causes the linea alba, so the fascia that's in between the two rectus muscles, to stretch. So it's not technically a hernia because the layer of connective tissue has not been breached. The contents are still within the abdominal cavity, but because it's been stretched, it's a little bit weak, and it does allow bulging of the contents. So the literature varies. We have been asked to look for these in patients who notice this swelling. Literature varies. Some articles say 2.5 centimeters and greater, some say 2.7 and greater. And the clinical look to them is a little different. So you end up with a linear bulge down the midline, often caused during pregnancy, and after pregnancy the muscles just don't knit back together as closely as they were, and obviously sometimes not during pregnancy. Lumbar hernias, I'm just going to spend a second on. So they are rare. They're most common in males, age 50 to 70 for some reason, and it will present as a posterolateral mass or sometimes with back pain. And the defect is going to be in the lumbar muscles. It's going to be below the ribs and above the iliac crest. You're not really going to have weakened fascia where the bones are supporting it. So it's going to be between the lower ribs and the iliac crest. It can contain omentum, fat, can also contain bowel or other organs such as stomach, spleen, or even kidneys. And just to look at the anatomy, so different lumbar hernias shown here, and imaging, CT, you can see that there's a large lumbar hernia on this image containing bowel, which actually has contrast in it here. Spigelian hernias, they're not that common. They can be quite symptomatic. We have been asked to look for these before. It occurs at the lateral margin of the rectus abdominis muscle. And so you're going to examine the patient in the transverse plane, is usually the easiest, and you're going to start at the umbilicus and move inferiorly. They tend to not cause much swelling. You may have a small palpable mass that the patient can show you, which is very helpful. Oftentimes the symptom is just pain when lifting or straining. So you're going to examine the patient in the supine position, but if you can't get the hernia to show up once you've asked the patient to do Valsalva, also worth standing the patient up to see if you can elicit the hernia. And this is just an ultrasound example here showing, the rectus muscle and the defect here between the rectus and the obliques. So a Spigelian hernia, so we're just looking at a diagram of where they occur. So it's a fairly easy location to examine, but they are usually quite small, so they can be a little tricky to find. And again, just a look at where the defect is between these two sets of muscles here. And some imaging examples of a Spigelian hernia. So this is a CT of a large Spigelian hernia containing bowel here. And you can see the rectus abdominis muscle here, the external obliques over here, and just an ultrasound example, rectus and obliques, and a defect here, fat-containing hernia here. So we're going to spend most of our time on inguinal hernias. So an indirect inguinal hernia is a protrusion of the peritoneal sac and contents through the internal inguinal ring into the inguinal canal, sometimes continuing to the scrotum. And we're going to look at some diagrams to help us understand where that is. So it occurs lateral to the inferior epigastric artery, the indirect. The direct is a protrusion through the weakened inguinal canal floor, medial to the inferior epigastric artery. So that is the distinction. So the indirect occurs lateral to the inferior epigastric artery. The direct occurs medial to the inferior epigastric artery. So obviously we need to find this inferior epigastric artery. And why does it matter whether we can tell the physician ordering the ultrasound whether it's indirect or direct? Well, doesn't really matter much to us, but the surgeon for surgical planning sometimes appreciates knowing what kind it is before he gets in there, because the mesh they use and the way they do the surgery is a bit different. So if you can save the patient from an unnecessary CT by telling the surgeon exactly what kind of hernia is, it's quite helpful. Okay, and just having a little trouble with my slides again. Okay, so just a diagram here to help us understand the difference between direct and indirect hernias. So this is the inguinal region here and inguinal canal. So there is a inguinal ligament that runs along the line of the groin, and this is the common femoral artery here. And the inferior epigastric artery is this vessel right here. So it's going to come off of your artery and it extends superiorly. Your indirect hernia is going to occur lateral to this vessel. So it's going to occur over here. Your direct inguinal hernia is going to occur medial to this vessel. So on the diagram to the right here, you can see how closely positioned your hernias are and your proposition is. So sorting these out is sometimes tricky. The neck is not always easily visible. So finding the inferior epigastric artery, trying to see if the neck is lateral or medial to this vessel, and that tells them what type of hernia we're dealing with. So with a transducer aligned parallel to the inguinal ligament, you're going to sweep cranially and try to identify the inferior epigastric artery coming off the external iliac artery. I think I said the common femoral artery before. It's the external iliac artery, so you're a little bit further up in the pelvis. So then you're going to have the patient perform Valsalva, and that is usually effective. Sometimes people don't understand how to do an effective Valsalva, so I find a cough is also very effective as long as they don't move too much while they're doing it. So a direct inguinal hernia will be seen arising medial to the inferior epigastric vessels, like we mentioned. You're going to examine it in two planes like we do everything else, and examine the patient in the upright position if needed. So if you can't find the hernia, it is worth standing the patient up just to see if you can elicit that hernia. The contents of a direct inguinal hernia, they remain quite medial. So the contents tend to go towards the pubis. This thing keeps freezing on me. Sorry, just give me a second here. So the problem I'm having, Rebecca, is the window. If I close the window, if I minify it, it freezes. But if I leave it open, it's blocking my view of my slide.
Can you move it over to the side? Like, can you move it off to the side?
I'm trying to do that, and it doesn't seem to want to let me move it from the right-hand side of my screen. Yeah, it won't let me move it. So I keep having to close it so I can see the words.
Oh. I noticed that sometimes when you're moving through, like, these little arrows are at the bottom of your screen that looks like you can click them to advance the slides, but I noticed they're not there right now, so maybe that window has to be open for that as well.
So how do I open that window?
Like the little window that you said blocks your screen. Do you have that up now?
Yes, it's up now.
Okay. Like what was happening was down in the very bottom left-hand corner is these faint little arrows were showing up to go right and left that it looked like you could click on, but it's not showing them up right now on my screen.
Oh, and I wasn't seeing anything on my screen.
Okay.
Okay, let me just see if I can figure this out, because otherwise I'm going to have to keep stopping over and over and over. I have audience view. What is that? That's not what I want. Why won't it let me move this thing? Yeah, it won't let me move it. Wonder if I click audience view, can I read that? I might be able to read it from the audience view. Okay, that might work. It's really tiny, but I can see it.
Okay.
Okay.
And what slide are you on now? Just because we can note to Julie what's
I don't have the numbers for my slides on when I'm
Okay.
doing a presenter view here.
Maybe we'll just tell Julie that during the direct inguinal hernia ultrasound, we'll try to flag this slide somehow so that she knows to come up, keep
Okay.
listening and cut this part out.
Okay. I'll take a
And just
picture of it.
make note of how much this time and the time before that on like your second or third slide where we had another break.
Okay.
Just so she doesn't leave anything there if she doesn't listen to the whole thing.
Okay.
Okay.
Okay, I'm gonna try it. Try to see if I can read that. Okay. So direct inguinal, I'm just going to start this slide over. So with the transducer aligned parallel to the inguinal ligament, you're going to sweep cranially until you find the inferior epigastric artery arising off the external iliac artery. And I think previously I said the common femoral artery, but it's actually the external iliac artery. So you're a little further into the pelvis. You're going to have the patient perform the Valsalva maneuver, so increase the abdominal pressure. And some people don't really understand how to do an effective Valsalva maneuver, so I find sometimes a cough is very effective, as long as they're not moving too much when they do that. So direct inguinal hernia will be seen arising medial to the inferior epigastric vessels. You're going to examine them in two planes, and you're going to examine the patient in an upright position if you cannot find the hernia. So sometimes that's very helpful. So the contents for a direct inguinal hernia tend to arise medial and they remain medial. They don't tend to head down the inguinal canal like the, sorry, just having a little trouble with my slides again, like the indirect. Okay, so with the direct inguinal hernia, you'll sometimes see just a fat-containing hernia. You can see peristaltic bowel in it sometimes. And the herniation should be evaluated for signs of incarceration and strangulation, which we'll talk a little bit about. So the patient will then release Valsalva, and you will apply pressure with your probe to see if it reduces. So can you push the contents back into their normal abdominal location? Bowel should demonstrate peristalsis if it's normal. There should be blood flow in the wall of the bowel if it's there, and the bowel wall should be less than 3 millimeters in thickness, and you should see normal bowel wall layers there. So these are just some examples of direct inguinal hernias. This is an ultrasound of the left groin, demonstrates a hernia neck medial to the left inferior epigastric artery, and you can see the arrowhead here pointing to the epigastric vessels, the inferior epigastric vessels, and the neck in this left groin is medial to those vessels. And again, this is just another very blown up view of it. And here's a color image, so you can see the inferior epigastric vessels here, your external iliac artery and vein here. Your hernia is medial in the right lower quadrant, right groin here. So the neck of the hernia is back here. And with Valsalva, you can see there's protrusion of the fat further into the outside the abdominal cavity. So we're going to talk a little bit about indirect inguinal hernias. Now, this is the most common inguinal hernia that we see. For those, the transducer is positioned very similarly. This is worded differently, but basically your probe is going to be lined up with your groin. You're going to find your external iliac artery. You're going to sweep a little bit caudally till you see your inferior epigastric artery arising off that. You're going to make sure you're parallel to the inguinal ligament or the groin. And you're also going to see the spermatic cord in this region. So you don't want to mistake spermatic cord contents for herniated tissue. And we'll look at a couple of normal examples of the spermatic cord so you can see what it looks like. With Valsalva, the spermatic cord tissue will move a little bit, but it's not going to slide and expand like a hernia would. So you shouldn't, if you see enough of these, you shouldn't mistake it. So again, you're going to get the patient to perform Valsalva. You're going to examine them in 2 planes, just like any other hernia. You're going to examine the patient upright if needed, and you're going to look for the same signs of reducibility and make sure there's no signs of incarceration, strangulation. So here is the image of a normal spermatic cord. This tube right here is the vas deferens. You'll have some connective tissue, nerves, etc., all traveling down in the spermatic cord with a lot of blood vessels. So this is the normal spermatic cord here. And you won't see this slide around. Obviously, this is going to be in male patients. You won't see this slide around like a hernia. Okay. And so when you're looking for an inguinal hernia, the hernia will be seen, if it's indirect, it will be seen protruding anteriorly towards the transducer from its origin lateral to the inferior epigastric artery. So the herniated tissue, it then turns medially anterior to the inferior epigastric artery, and it extends inframedially as it sort of travels parallel to the skin and then heads down the inguinal canal. And I'm just going to look at this diagram again so you can see. So the indirect hernia will occur lateral to the inferior epigastric artery. It's going to come towards you, so superficially towards the transducer a little bit, and then it's going to swing medially and inferiorly. So it's going to cross in front of this inferior epigastric artery, and it's going to head down the inguinal canal. The direct inguinal hernia is going to happen medially to this vessel, and its contents are going to stay medial. It's going to head over this way. And again, just another view of where the contents tend to be. So direct here, happening medial to these vessels, and the contents stay medial. In indirect, happening lateral, and it heads usually, if it's large enough, it will head down the inguinal canal. The most difficult ones of these are the small ones where they just protrude a little bit, and if you can't see that neck, it's very challenging to tell what type you're dealing with sometimes, and sometimes we can't. So some examples of an indirect inguinal hernia on ultrasound here. So this little arrow is telling us that it's the left inferior epigastric artery. Hernia neck is lateral to the vessel. So this is an indirect hernia containing fat. So you can see how well this blends with the tissues, the connective tissues and the fat that are normally in this area. So if you don't get the patient to perform Valsalva maneuver and see this material move, it is very hard to pick out sometimes. So Valsalva is very helpful. And again, just another look at the neck of this hernia. This is one that's a little bit easier to see because it's hypoechoic. You can see that its neck is right here. And this is a nice example in a younger, thin patient. So beautifully seen hernia here, neck of the hernia here, and with compression, this hernia is seen to almost completely reduce. So the contents have mostly moved back into the abdominal cavity, not fully. So it's a partially reducible hernia here. And so we're going to talk a little bit about femoral hernias. They're not that common, so they do protrude inferior to the course of the inferior epigastric vessels. They will lie medial to the common femoral vein, so they're a little more inferior to the other inguinal hernias, so they're usually in a slightly different location, so usually not hard to sort out what you're dealing with here. The swelling will be more on the upper medial thigh, as opposed to right up in the groin. So they're fairly uncommon. They only account for 3% of hernias. They are more common in females, and I think that's due to slightly wider pelvis. There is a high complication rate though. It's a fairly narrow opening, and bowel, for some reason, tends to want to go there. So these hernias tend to present with symptoms of strangulation requiring surgery. And this is just a diagram showing you where they occur. So the other ones are going to be up here a little higher. This one here is sitting medial to the common femoral vein and fairly low. So the swelling will actually be on the between the upper thigh and the groin. And here's just an ultrasound of some normal anatomy. So this is actually the inguinal ligament, which we can see if you're lined up right, and common femoral artery and vein. And so you're going to be looking medial to the vein. So in this resting patient, this is normal anatomy. And again, here in this resting patient, this looks normal. You have your artery, your vein. Doesn't look like there's much happening here. With Valsalva, however, you can see that there is a good size femoral hernia protruding with the neck right here. And this is a femoral hernia over here, which looks to contain bowel. So just going to look at, we're going to get into this in a little more detail, but strangulated femoral hernia is shown right here. So strangulated hernia usually will have a narrow neck. So it's cutting off its blood supply essentially, and can lead to some pretty serious complications. So this is not a normal looking hernia. It has fluid, it's distended. So real-time assessment of hernias, that's where ultrasound has the advantage over the other modalities for most things. We can look at it in real time. We can see how it's moving. We can see what happens when we press on it. We can see what's happening with the blood flow in it in real time. We can see if we can elicit it. If it's not showing at rest, we can use some maneuvers like Valsalva and standing the patient up erect, which can make the hernia show itself a little bit better. These are all things that CT and MRI just can't do. So real-time compression, it's used to assess the reducibility and tenderness of a hernia. So compression of a hernia, you want to see if it's reducible. So can you push the contents back into its original site? If it's completely reducible, it tends to move completely back in. It will usually have a broad neck. You can have partially reducible ones where most of it goes back in, and you can have completely non-reducible hernias, which would then be considered an incarcerated hernia. So they tend to have a narrow neck. An incarcerated hernia isn't necessarily a medical problem. You can have fat that's stuck there that doesn't want to move back in, doesn't want to reduce. If the patient has no symptoms, they're probably not going to get too worried about that. If you have bowel loops that are stuck out there though, an incarcerated hernia they'll be the ones that you'll tend to see eventual strangulation, so the blood supply will eventually be compromised. And we're going to come, we're going to come back to these videos. I'm going to finish the slides and then we'll come back to them if we have time. So hernias and Valsalva maneuver. So it's a critical component. We've already talked about that. You have to see it move. It causes intermittent increase in abdominal pressure. So if you're going to see the hernia, it's going to be with increased abdominal pressure. And sometimes that's the only time we will see the contents. And when the patient relaxes, sometimes it completely goes back in. So we're going to talk a little bit more about the complications. So a hernia, again, is considered incarcerated if the tissue becomes trapped and it's unable to be reduced. And it's strangulated if the blood supply to the tissue is compromised. So it loses its blood supply, therefore its oxygen supply can lead to bowel ischemia. And it is a medical emergency requiring immediate attention. So if you have an emergency request for a hernia, sometimes they really are emergent requests. Patient will be in significant pain, and color and Doppler should be used to demonstrate the absence of flow. You don't want to really just use color and assume that there's flow there. Color and bowel, there's a lot of artifacts. There's a lot of artificial flashes that happen there. You want to be able to drop that Doppler spectrum on and hear or see real arterial or venous flow before you've decided that there is a real blood flow there. Don't rely on just color. So signs of strangulation is thickening of the wall of the herniated bowel loop that is greater than 3 millimeters, free fluid or fluid in the herniated sac, intra-abdominal bowel dilatation, and lack of blood flow to the bowel wall. And so just to explain why the intra-abdominal bowel tends to dilate, if you have a strangulation here and the contents of the bowel inside the abdominal cavity is supposed to kind of flow freely through this loop of bowel, obviously it can't do that. So this piece of strangulated bowel is going to cause an obstruction of the rest of the small bowel inside the abdomen. So when you see or suspect a strangulated hernia, you should look inside the abdominal cavity for dilated bowel loops as well. And this is some ultrasound examples. So this is a bowel obstruction caused by a strangulated hernia. So lots of dilated obstructed bowel loops and an inguinal hernia here that has been strangulated. So this fluid in the hernia should tip you off that there's something not quite right there. That's an abnormal look to a hernia. And again, strangulated hernia here. So not too narrow of a neck, it's fairly wide, but this is an abnormal appearance. So you have fluid in the bowel. You also have free fluid in the herniated sac. So this is suspicious for a strangulated hernia. This is just an interesting case that I found when looking through the literature. A 4-week-old girl. She came in with a palpable mass in her right groin. And this is a lovely ovary that is herniated through her inguinal canal, follicles and all. And in the farthest to the right, you can see that the ovary has good blood flow, so it's not strangulated, which is great. And you can see that it's emanating from lateral to the femoral, or sorry, to the inferior epigastric vessels here. So this is indirect hernia. And some examples of hernia repairs. So we get asked fairly often to look at someone querying a hernia when they've had a previous repair. And these are very challenging. So the mesh that they put in causes a lot of acoustic shadowing, and they're very hard to see through. So we usually struggle to see beyond the mesh enough to tell, the surgeon whether there's another hernia here. Sometimes we can see complications. We can tell them sometimes, as in the picture on the right here, if the mesh is maybe not held. So this mesh looks like it's buckled up. There's some fluid around it. So this mesh is probably not sitting where it should. And just an example of one of the types of hernia repairs. And this is what the mesh looks like that they use, a hole to allow the passage of the blood vessels or the spermatic cord, whatever it is that, wherever they're putting this. So the mesh shape and size will vary depending on the type of repair. And I will go back to the videos in just a second. I thought I'd just leave you with this slide, which I'm sure we all can relate to. And just going to pause this for a second.
This conference will now be recorded.
Okay, so I'm just going to show you a video here now of a hernia with a patient performing a Valsalva maneuver and how helpful it is to see the hernia when you do that. Just going to play this here. So this is a bowel containing hernia. You can see the normal peristalsis that is in this herniated sac here. And with pressure going to be applied here. And then it completely reduces as well. So I'm going to close that one. Pause.
This conference will now be recorded.
Okay, and then just one more video. We're just going to watch another example of how much easier it is to see when the contents are moving with Valsalva here and pressure. You can see this kind of blends a little bit with the surrounding tissue. There is a bit of a neck you can see here, but when you get the patient to perform Valsalva, you can see how much easier it is to see. This would be the neck right here. Okay. So I'm just going to go back to my PowerPoint here. Okay. And I'm just going to go back to where we were. Sorry, it's a little disjointed with doing things online these days. And my references. And if anyone has any questions, I hope this has helped you a little bit. And if you have any questions, feel free to fire me off an email and I will do my best to answer. Thank you.